Friends, whatever is common is always controversial, and the ACL reconstruction is one of the very, very common surgery which is performed all across the world. And that remains true even for the ACL reconstruction. So whenever you're doing an ACL reconstruction, after some times you might face a situation where you have a big tunnel widening, failed graft, and failed ACL reconstruction. In those situations, one has to come out and bail out the situation with the help of something known as perfect graft. So can there be a perfect graft? If there cannot be a perfect woman, there cannot be a perfect graft. So you have to find out which one is a good graft. And the best graft will be the one which stays back and it works for years, and then you have a very good stable knee. So one has to understand that there is no perfect graft in this world. So what graft choices we have in revision ACL surgery, and the data on it, which is very, very controversial, whether we have to get an autograft or allograft, or a tissue which mimic like a graft, like synthetic graft or auto tissue banks, which have been now flourishing across the Western world. In our scenario, we have three options, which is commonly practiced. One is the hamstring tendon, which is primarily used for your ACL reconstruction in the first situation. So at revision position, you may not be in position to take out the hamstring tendon. The second commonest graft which can be used in your clinical practice is the patella tendon, that's patella tendon bone. And third is the quadriceps, which is gaining a popularity as far as the European world is concerned. So as Parag has said that there is a number of ACL reconstruction performed per year, this is US data, which shows that almost 3 lakh ACLs are performed per year. And almost 75% have got a very good recovery, but there is a 20 to 25% patient who land up in problem. And this problem, they have a patient expectation from surgeon as far as the ACL reconstruction is concerned, and then have to have an ideal graft which fits the situation. So what is the goal in ACL reconstruction is to restore, prevent, and return to sports as far as that patient is concerned. Worldwide, if you see the failure rates, the technical errors and trauma secondary to ACL reconstruction is the commonest cause for your ACL failure. And in these situations, one has to have a best graft. And the best graft could be one which mimics the anatomical properties of intact ACL, biomechanical properties, and rapid biological incorporation and minimal graft site morbidity. In our clinical practice, we might come across with a graft which is broken, like you can see on your right side. There is a complete graft failure, and those situations one has to have a very high strength anatomical position of the ACL new graft with rigid fixation so as to give a very good result. So what is the graft selection criteria as far as this revision ACL is concerned? One has to find out what is the amount of instability, what kind of peripheral instability the patient is suffering from, and the imaging and the MRI so as to get a proper orientation of the knee joint. One has to understand that the instability is the clinical symptom which patients comes with, and often this revision situation, the instability is gross instability. There could be the pivot shift which is grade 3, and in those situations the peripheral reconstruction do help. So what are the graft choices in revision ACL? Primarily we can do a patella tendon graft, which is a very, very common and popular graft, because remember there is a tunnel widening in primary ACL reconstruction. In those situations you want your graft to heal and will get biomechanically adjusted in the native environment. The quadriceps tendon is picking up now because of the more knowledge about the quadriceps anatomy, the 4 tendons, and you can easily take out a graft. Allografts, luckily or unluckily, we don't have the allograft in India, but I'm sure another 5 years down the line we'll have an allo bank shortly in Mumbai. So biological failures of ACL graft has been studied, and they found out the graft which results in incomplete ligamentization could be disorganized, and it's usually non-viable. So one cannot consider such patients for the surgery. You have to consider them for a revision surgery. The graft choices usually are BTB, semitendinosus, and quadriceps. One may consider the semi-T graft from the other side, but usually it is a dictum in sports and athlete. You should not touch his opposite knee unless the patient demands the hamstring graft from the other side. The commonest graft which commonly used is BTB and quadriceps tendon for those athletic population. And to reduce the donor morbidity, site morbidity, one can do a bone grafting of patellar tendon with the remaining part of the bone so that you get a better outcome and anterior knee pain is reduced. Or it could have the bone filling effect, which will reduce the donor morbidity, which has been described by many researchers, including Guy Morak. The graft for revision usually could be the hamstring graft, where you can multiply those grafts. You can make it 4 strand, you can make it 5 strand, you can make it 6 strand, depending on the length and the availability of the graft tissue on your platter. The bone patellar tendon bone is the best. Usually we don't touch the opposite knee, but if there is a multi-ligament reconstruction and failure of ACL, PCL, one can attempt a removal of BTB from the opposite side also. The allograft remains the mainstay when you are dealing with the multi-ligamentous failure instability like ACL, PCL, and the lateral collateral ligaments. The quadriceps tendon is a useful graft. One has to study and understand that quadriceps is a very, very big muscle. It is formed by 4 muscles, and the tendinous part can be easily removed as a graft, and you can still get a better outcome and good result for the quadriceps tendon as far as the graft choices are concerned. The quadriceps graft is now getting a very, very good popularity in Western world as well as the European population, and they found out for it becomes a mainstay in revision ACL reconstruction and PCL reconstruction because of its length and the diameter it provides for your ACL reconstruction, especially in revision situations. So quadriceps can be taken out along with the patellar tendon, but usually should be avoided because the cross-sectional area is good, but there could be a chances of a patella fracture, and these situations are very difficult to treat. So it's advisable that once you take a BTB, you should not take the quadriceps tendon from the same graft so as to not create a stress riser as described by Charlie Brown. The important consideration for your ACL reconstruction in revision situation is the activity level and patient expectations. Remember, the compliance and surgeon experience play a very important role because everybody may not be expert in taking a BTB graft, and availability of graft is also very important. And knowing this factor, BTB remains the gold standard because it has proved time and again that it is an ideal graft for high-level athlete with quick return to sports. In summary, the BTB graft usually works very high because it's got high tensile strength, and the potential to lose quadriceps function is very, very less as far as the BTB is concerned. The only problem is anterior knee pain, which can be reduced by bone grafting. So graft choices, whether the hamstring works in revision situation, the hamstring usually you don't get the diameter which is fitting, and biology can be a compromise. A less donor morbidity is the important aspect of this graft, but yes, not to do in high jumpers and the long jumpers or the hurdlers where you require the medial pivotal activities. The hamstring graft, although it's advantageous, some disadvantages, the weak soft tissue, slower incorporation into the bone tunnel, the weak flexion torque beyond 90 degree, this can lead to early failures. Quadriceps is the important graft in today's scenario where you have biomechanically stronger and larger diameter, and this can work in the better choice for the patient. The graft choices, allograft, we don't have availability of allograft, but the common allograft which are commonly used is the bone patellar tendon bone. We have a chance of using this in few situations because we had a small allo bank with us where we have used the tendo Achilles and the tibialis anterior allograft. And this allograft has shown a very good result as far as healing is concerned. There is a good paper by Christopher Harner, and they have found out that clinical outcome of allograft versus autograft in anterior cruciate ligament reconstruction is far, far better. So what is the strength which you are looking at? You are looking at almost more than 2000 Newton strength for your ACL failure, and this can be easily incorporated by your allograft. And the hamstring graft, usually a quadruple hamstring can mimic those tensile strength. The outcome of BTB versus hamstring has been discussed, and it has been found out that BTB has got higher incidence of the better outcome as regards to the hamstring is concerned. So no significant difference was found as far as laxity in clinical outcome in BTB versus hamstring graft. Autograft versus allograft is controversial. Some people say that it has got better clinical outcome, but again, the higher failure rate in young athletic population is noted. In summary, the consensus on which graft to be used, the appropriate, the evidence is lacking. The BTB and bone allograft are most predictable than the other allograft. The choice ultimately depends on the surgeon and the patient, and it should be done with a good confidence in the patient. Thank you very much.